So, good morning. Today's topic is approach to anemia and we will cover iron deficiency anemia also. So, how is anemia defined? So, anemia is defined by hemoglobin or hematocrit values more than 2 standard deviations below the mean for the age and gender. So, there is hemoglobin wise WHO definition according to the age groups. Children age 6 months to 6 year 11 gram percent, children age 6 years to 14 years 12 gram percent, adult males 13 gram percent, adult females 12 gram percent and pregnant women 11 gram percent. So, it is 11, 12, 13, 12, 11, easy to remember, highest value in adult males. Okay. So, how anemia is classified according to the underlying mechanism. So, what may be the mechanism of anemia? Blood loss, increased destruction of RBCs and decreased production of RBCs. So, in blood loss it may be acute or chronic. Chronic blood loss may also lead to iron deficiency anemia because iron is lost in the blood. Increased destruction may be because of hereditary causes or acquired causes. Hereditary causes, the problem may lie in the membrane or may be in the cytoplasm, which is enzymes or hemoglobin. So, in membrane defects, the most common are hereditary spherocytosis, hereditary elliptocytosis. Enzyme defects common are G6PD deficiency and PK deficiency, pyruvate kinase deficiency. Hemoglobin synthesis problem is called as thalassemia, quantitative decreased production of hemoglobin, which is thalassemia. Then acquired causes, which includes autoimmune hemolytic anemia, HUS, TTP and DIC, hemolytic uremic syndrome, thrombotic thrombocytopenic purpura and disseminated intravascular coagulation. So, these are macroangiopathic hemolytic anemias. These all three are type of macroangiopathic hemolytic anemias. Then malaria and transfusion reaction because of alloimmunization or mismatch. So, these also will lead to hemolysis, RBC will break down. So, impaired RBC production, the deficiency, nutritional deficiency like iron, B12 or folate. Iron we will see in detail later on. Then bone marrow suppression because of aplastic anemia where the bone marrow is not producing enough cells or because of some infiltration of abnormal cells or abnormal material like leukemia. In leukemia, abnormal cells will infiltrate in bone marrow and there won't be any space or nutrition available for normal cells to grow. So, there will be myelosuppression, there will be decreased formation of the new cells, but the leukemic cells will be flooded in the bone marrow. So, cells are not deficient, there are cells, but only abnormal cells. Then storage disease, if storage material is deposited there, there is no space for normal cells to grow. And osteopetrosis. What is osteopetrosis? Any idea? Osteoporosis, pores means osteoid is, there is some decreased mineralization in the bone, and osteopetrosis is opposite of that, increased mineralization of the bone. So, bone is more thicker and it is encroaching the bone marrow. So, in bone marrow again there is no space, decreased space for normal cells to grow. So, we will see one case. A 7-month-old male child presented with pallor and hepatosplenomegaly. There is history of 2 transfusions till now. Liver is 6 centimeter below costal margin and spleen is 6 centimeter below costal margin. Normal facies, there is no hemolytic facies, and PS is showing target cell. What is the possibility here? कुछ आइडिया? इस एज में हेपेटोस्प्लेनोमेगाली के साथ और ट्रांसफ्यूजन हिस्ट्री है, थैलेसीमिया, वेरी गुड, है ना? इस एज में व्हाट इज द कॉमन एज ऑफ थैलेसीमिया मेजर प्रेजेंटेशन? 6 months to 2 years, this is the most common age. Some cases may go beyond either earlier or later, but most common age is like this. So, in such cases how do we approach? First thing, whenever any child comes, we see the vitals, whether any emergency thing is there in this, maybe the hemoglobin is 2 only and require immediate intervention, immediate maybe going into CCF. So, we need to admit and then arrange for the blood also and CCF management also. Is patient symptomatic? If even if vital signs are normal, is patient symptomatic because of anemia? It means anemia is severe enough to cause problem to the patient, so may need blood transfusion for that. Is transfusion therapy emergently indicated in these situations like congestive heart failure, syncope, hemodynamic compromise? Because of anemia, if these are there, then we need to transfuse in emergency. Is there any blood loss which may cause anemia? So, acute blood loss, long standing bleeding or hemoglobinuria. Hemoglobinuria also may cause loss of iron, at least in that, and actually RBC anyway lies, but there will be loss of iron also. If there is no hemoglobinuria, then iron will be again utilized in the body only. So, maybe in iron overload in the body, but in case of hemoglobinuria, even despite hemolysis, there will be iron deficiency anemia associated with that. Then other questions for cause, we also want to find out the cause of anemia. So, take history of drugs, what patient is taking. If they are taking aspirin or NSAIDs, then possibility of GI blood loss may be there. Even we may not be able to see the blood loss because it is inside the gastrointestinal tract. It will take some time to come out through the anus. So, other things what we can ask is the if there is any intake of or administration of chemotherapy drugs, immunosuppressive drugs, folate antagonists and anticonvulsants, these causes marrow suppression directly by the drugs. Then penicillin, sulfonamides or oxidant drugs may cause hemolysis, especially in G6PD deficiency patients. So, is there any organ dysfunction? This question need to be answered when we see the patient, because associated problems, if they are there, then maybe it is anemia of chronic disease. The associated problem may lie with liver, kidney, adrenal, thyroid, anything. So, all organ function we should see clinically first and then confirm with the lab reports. And chronic inflammatory or connective tissue disorders, autoimmune disease or immunodeficiency. So, if signs of these are there, then these are associated with anemia of chronic disease and or autoimmune hemolytic anemia. At one in one part of body, if autoimmunity there, then body has tendency to have autoimmunity in other part also. So, AIHA is commonly associated with other autoimmune disorders. So, if you find any other autoimmune disorders, then chances of AIHA is more. Then what other questions for cause? How old is the patient? How age is important to find out the cause? Nutritional iron deficiency is never responsible for anemia before 6 months of age in term infant, and in preterm before doubling birth weight. It won't, nutritional anemia won't be there, because even if mother is deficient in iron or B12 or folate, the child will actually get the milk will not be deficient, mother's milk will not be deficient. So, child will get the nutrition despite the mother is deprived of that. In the newborn period, if anemia is presented, then the common causes are recent blood loss, then isoimmunization. What is isoimmunization? Like RH incompatibility, ABO incompatibility. Okay. So, isoimmunization means immunization with own antigens. So, because of that some antibodies are formed, some are not formed, then the child, the infant which is there and if any incompatibility, then there will be hemolysis in the infant. So, congenital hemolytic anemia. So, what are the congenital hemolytic anemia commonly present at newborn? These are HS, G6PD, hereditary spherocytosis and G6PD. Then torch infections. Torch infection is toxoplasma, rubella, CMV, herpes, these congenital intrauterine infections. So, if these are there, then these infections may lead to anemia in newborn period. Anemia first detected at age 3 to 6 month, not at birth, but 3 to 6 month first anemia detection is there. Then what are the likely causes? So, it is likely congenital, beta thalassemia may be there, or diamond Blackburn anemia may be there. It is usually masked by fetal hemoglobin. That is why they do not present at the time of birth or initial 3 month of age. Then gender, G6PD is X-linked recessive. So, when X-linked recessive disorder, then it will manifest only in males, not in females, except the rare chances of X lionization or Turner syndrome in female. So, because other X is there in the female to actually compensate any loss in the X chromosome functionality. So, all X-linked recessive disorders will manifest in the males only. Then ethnicity, thalassemia is common in Mediterranean and Asian region, HBS and HBC is common in African region. Neonatal jaundice, if it is there, then HS and G6PD, as I told, these are common cause of neonatal jaundice and neonatal hemolysis. Then family history of chronic jaundice, gallstone and splenectomy. If this is the history, then these are suggestive of some hemolysis going on. So, if congenital hemolytic anemia is autosomal dominant, then HS is a possibility. Autosomal recessive, then thalassemia, sickle cell anemia is a possibility, and X-linked recessive, then G6PD deficiency is possibility. Cow's milk or delayed weaning may lead to iron deficiency anemia. If infant is taking goat's milk, then folate deficiency may be there associated with goat's milk intake. Now, how do we detect pallor on examination? So, these are the ways. One is this palmar pallor can be seen with comparison of our own hand with the child's hand, you can see the difference. Then provided that we are not anemic ourselves, and then tongue also can be seen for the pallor. Then this is nails and conjunctiva. This is very important actually, but if conjunctival congestion or conjunctivitis is there, then there will be increased blood flow in the conjunctival vessels and you may not be able to realize the pallor properly. But if this is not there, then this is the best site to see. What is this? Icterus, okay. And this one? Gums. What is this? Bolo? Fast. Array, gum hypertrophy or spongy gums. Where do you see gum hypertrophy? Especially if associated with these bleeding spots, petechiae and purpura. Okay. So, where do you see? This is AML, AM3 or APML, and other differential is scurvy. In scurvy also spongy gums may be there, and even petechiae you may see because of vessel wall issue. This sign is edema. Why it will happen? What is the relation with anemia? congestive cardiac failure. Okay. Anemia will be there, then increased circulation, increase blood volume to compensate that anemia. The body tries to increase the blood volume, and that will lead to congestive heart failure, and that will lead to back pressure and hepatomegaly and edema. So, if this is there, then child is serious. What is this sign? Nail shape, spoon shape, very good. Koilonychia it is called as in iron deficiency anemia. Angular cheilitis in iron deficiency anemia. What is showing? These spots, cafe au lait spots, and it is seen in Fanconi anemia and some other like even isolated way it can be found in normal also, but in if we find out the if we approach the patient with anemia, then if we find these spots, then Fanconi is the possibility. This one, chipmunk facies, hemolytic facies because of maxillary hyperplasia, where the actually because of chronic anemia there is increased blood formation in the other bones in the body, not only the long bones or the pelvic bones, flat bones, the other part of body also start making the blood, other part of the bone marrows. So, that is why there will be hyperplasia of maxillary bone. What is this sign? Color, nuchal hyperpigmentation, in which deficiency? Vitamin B12, very good. And these are lymphadenopathy. We should see all these signs for cause of anemia also, other signs to detect other signs to correlate, because anemia is a very like common finding. So, there may be so many causes related to the different systems. So, if we examine all the systems properly, general examination is proper, then we will be able to gather more information to have better differential diagnosis list in our patient. So, lymphadenopathy we should see all areas, then hepatosplenomegaly we should see. So, how we approach investigation wise? In any patient with anemia, after our history and proper physical examination, we will need CBC indices which is included in the CBC, retic count not included we have to ask, and peripheral smear not included we have to ask. So, CBC, retic count, peripheral smear. So, these are mandatory to approach any patient with anemia. So, how do we approach later on? How retic count is important? What are reticulocytes? Reticulocytes are actually newly formed RBCs, okay, who are losing their nucleus, but not completely lost. So, that is why there will be some bluish material inside, the RNA material will be remaining. So, this is seen in the peripheral smear as polychromatophils, because there will be some bluish hue. So, polychromatophils it is if reported in the peripheral smear, then it is reticulocytes. Otherwise, reticulocytes are seen with the different stains, and they will be counted in Coulter machine also. So, normal count is about 1 to 2.5% of RBCs. But in case of anemia, because when anemia is there, body tries to make more RBCs. So, retic count will increase automatically. So, in proportion of that degree of anemia, increase in reticulocyte count will be there normally. So, that is why we have to correct the reticulocyte count to interpret it properly. So, how do we correct? Corrected reticulocyte count is equal to reticulocyte percentage into hematocrit divided by 45. So, 45 we consider as normal hematocrit. Okay. If hematocrit is 45 only, then 45 divided by 45 is 1. So, whatever retic count we are getting, that is corrected. So, there is no difference, but if hematocrit is less, okay, then corrected retic count will be less, like 15 is the hematocrit. So, 1/3, okay. 15 is hematocrit and retic count is 9%. So, corrected retic will be 3%, 1/3. Hematocrit decrease 1/3, then retic count also we have to decrease 1/3. So, 9% is response because of anemia. So, because of anemia it is falsely high, actually retic will be less. So, that is the principle. Then absolute retic count also can be calculated, retic percentage into RBC count per microliter divided by 100. Okay. Basically in report it will come as percentage. So, if we want to find out per microliter, then it is percentage of RBC. So, we will multiply with RBC count. So, absolute count will come. So, importance of this absolute count is in case of aplastic anemia, where severity is defined by absolute reticulocyte count less than 20,000 per microliter. So, that is why it is important. So, what this peripheral smear is showing? This is showing hypochromic microcytic anemia, and there is one pencil cell, if you can realize here, this one. Okay. So, this is the pencil cell. Here what is the diagnosis? So, that is why peripheral smear is very important for anemia. Most of the differential diagnosis like will be narrowed up because of proper peripheral smear examination. What do you see here? These arrows. What is the difference between this RBC and this RBC? Smaller, size is smaller, and there is central pallor in normal RBC, and in this it is lost. So, it is more condensed. So, this is spirocyte. Few spirocyte may be normal, okay, but if spirocyte increased and same kind of multiple cells are there, then it is hereditary spirocytosis. Actually, looking at the smear, immediately pathologists may tell that this is hereditary spirocytosis. We do not need any test. So, these are bite cells and helmet cells. So, basically cystocytes, and cystocytes are found in those three macroangiopathic hemolytic anemias, HUS, TTP, DIC, or prosthetic valve. This is very easy, and diagnosis written also here. Okay. Sickle. So, this is sickle cell, and what are these? Target cells. Target cells are found in hemoglobinopathies, thalassemia more common, but sickle cell also it may be there. So, these are spiculated acanthocytes, schizocytes and acanthocytes. These are acanthocytes. Okay. One more terminology, if small spikes, then it is burst cells. So, that may be storage defect also, means if not slide is not prepared properly and not blood is not stored properly, then there will be some crenation of the RBCs. So, these are actually may cause hemolysis again. Then this is very important and peculiar. Identify. ये सेल क्या है? न्यूट्रोफिल. उसमें क्या पेक्यूलर है? हैं? नहीं, थोड़ा तेज बोलो. अरे बोलो, जो बोल रहे हो वही तेज बोलो. मल्टी lobated, hyper lobated. Okay. So, if lobe number is more than 6, then it is hyper lobated. And this one macrovelocyte, okay, large RBC. So, macrovelocytosis and hyperlobated neutrophils, hypersegmented neutrophils, then it is B12 deficiency or folate deficiency, megaloblastic anemia. So, we do not even need bone marrow to identify megaloblastic anemia. Megaloblast term is related to bone marrow finding, but we need not to do that. If these findings are there, MCV is increased, we do B12 and folate level, correlate with that and diagnose and start treating and then see the response with the treatment. So, it will be sure that this was megaloblastic anemia only, but bone marrow is an invasive test, we do not need that. This is simple malaria. Uniform cells WBCs with open up nuclei, high NC ratio, nucleus is big, cytoplasm is less. क्या है ये? हाँ? ALL, very good. Blast, basically blast. We can't say ALL. These are blast, means immature cells are there. So, in nucleus there is immaturity, open up nuclei. The other smear, if you see somewhere, yeah, this is not open up nucleus. This is also lymphocyte, but this is condensed nucleus. Okay, here nucleus is open up, more like this all integrated DNA material is opened and the density is less and size is more. Okay, so in anemia, first see the MCV. If low, then iron deficiency, thalassemia, lead poisoning, chronic disease. These are the differentials. If high, then folate deficiency, B12 deficiency, aplastic anemia, pre-leukemia, immune hemolytic anemia and liver disease, or retic count increase because of any reason, then also your MCV will be high, because reticulocytes are bigger cells. So, if these are there, these are increased, then MCV will be increased, but we should interpret carefully, we should interpret with the peripheral smear. Peripheral smear में अगर polychromatophils ज़्यादा है और बाकी हाइपो माइक्रो या नॉर्मो ऐसे दिया है, तो ये MCV raised is not because of the large RBCs, it is because of large retic count. So, hemolysis, hemolytic anemia में भी ऐसा हो सकता है, high MCV. और if MCV is normal, most of the time hemolytic anemia will have normal MCV. If MCV is normal, then see the retic count. If retic count is high, then bilirubin to be checked, and if low, then see the other count. So, if high bilirubin, then hemolytic anemia. If normal bilirubin, then chances of hemorrhage may be there. Hemorrhage also will lead to high retic count. And if hemolytic anemia is suspected, first thing to see is Coombs test, whether it is autoimmune hemolytic anemia or non-immune, that we need to see. So, if Coombs test is positive, there is extracorpuscular lysis, causes may be autoimmune hemolytic anemia, which may be because of primary causes and secondary causes. Secondary causes means some other autoimmune diseases in the body like connective tissue disorders and drug induced. Then isoimmune hemolytic disease, ABO-RH mismatch transfusions. Coombs negative, then comes that congenital hemolytic anemias like hemoglobinopathies and enzymopathies and membrane defects, and extracorpuscular causes also may lead to Coombs negative hemolytic anemia, may be idiopathic or secondary causes like because of drugs, infection or microangiopathic hemolytic anemia. Then if retic count is low, then see the other counts. If WBC and platelet also low, it means there is problem in the bone marrow. So, bone marrow depression may be there, malignancy may be there, aplastic anemia may be there. So, we need to do bone marrow examination. And if WBC and platelet normal, then the problem is in RBC lineage only, then pure red cell aplasia is a possibility. If it is congenital, it is called as Diamond Blackman anemia, and it may be transient also. Pure red cell aplasia may be transient also because of some infection, or sometimes in infants about 6 weeks of age, transient erythroblastopenia will be there. Then increased WBC or increased platelet may be reactive because of infection. So, in our case that was discussed in beginning, thalassemia was the differential. So, for thalassemia what do we need to do? Immediately screen the parents CBC. So, you will have idea whether it is going towards thalassemia or no. So, in father CBC hemoglobin was 12.7, MCV 59.5, and mother CBC hemoglobin was 10.1 and MCV 64.6. So, both are having microcytic anemia. So, it means both may be having thalassemia trait. Okay. How do we confirm now? We have suspicion on CBC and indices. If both parents are trait, then chances of thalassemia major or transfusion dependent thalassemia is there in the baby. Now, confirmation. HPLC. What happened here? 2 transfusions till now. If you do HPLC, there will be transfused cells in that. So, which will alter the percentage of all kind of hemoglobins, because transfused cells will have HbA, adult hemoglobin. Okay. And in thalassemia we expect HbF, so that will be diluted. So, it will be difficult to interpret. We can do, but interpretation has to be proper, and the lab should know that when was last transfusion given. If it is more than 3 months, because RBC's life is 120 days, more than 3 months since last transfusion, safely we can do, no issues. So, what other way? Parents का HPLC कर सकते हैं, बिल्कुल. So, final confirmation will be mutation analysis in this case, because even if we screen the parents, we can only know that it is thalassemia minor, but baby may have normal also, may be thalassemia minor also, or may be thalassemia major also, all chances are there. So, exactly to know what baby is having, mutation analysis we need to do, because transfusion will be, the child will be receiving transfusion throughout life now. So, there will not be any 3-month transfusion free interval if it is thalassemia major. So, next is iron deficiency anemia. This will just quickly go through. So, this is iron metabolism, daily iron intake 1 to 2 mg, and through duodenum it is actually absorbed, and then in ferrous form it is absorbed, and with transferrin it is transported. 80% is utilized in bone marrow, and then there are other functions of iron also. So, total iron in adult is 4 to 5 gram in body, total iron will be there. So, this is how iron absorption happens in the intestine. The ferric form is converted into ferrous, and then it is absorbed, and partly it will be trapped in the ferritin, with ferritin in the mucosal cell only, and partly will be absorbed through the posterolateral basolateral membrane, and ferroportin is the transporter protein in the membrane, and then it will be again converted into ferric form, and then with transferrin it will be hollow, it will make hollow transferrin, and it will be transported in the blood. So, there is important regulator of iron absorption, which is hepcidin. It degrades ferroportin. So, that is why it will decrease the iron absorption. Okay. Hepcidin will decrease the iron absorption, just remember this. So, iron absorption happens in proximal duodenum. 10% of the iron ingested will be absorbed. Increased absorption in case of acidic pH. Heme iron has absorption independent of pH. Heme iron means कोई bloody ले रहा है तो, और ascorbate and citrate are weak chelators, and these will make the iron soluble and increase the iron absorption. In case of iron deficiency, ineffective erythropoiesis and hypoxia, there is decrease hepcidin expression. So हेप्सिडिन एक्सप्रेशन डिक्रीज हुआ तो आयरन एब्जॉर्प्शन का क्या होगा, जल्दी बताओ, इंक्रीज, अपोजिट चलेगा, ठीक है ना. डिक्रीज एब्जॉर्प्शन बिकॉज ऑफ फाइटेट्स, कैल्शियम, ब्रान, टेनिन्स, दीज चिलेट द आयरन स्ट्रांगली, सो देर विल बी डिक्रीज एब्जॉर्प्शन. सो ज़्यादा प्लांट बेस्ड अगर अपन आइटम खाएंगे, कैल्शियम सिरप साथ में लेंगे आयरन के, या ब्रान मीन्स ब्रान वो उसमें वीट के जो छिलके होते हैं ना उसमें होगा, देन टेनिन्स, टी, है ना. सो वी शुड नॉट टेक टी विद द फूड. आयरन रिच फूड अगर हम ले रहे हैं और उसमें टी भी ले रहे हैं साथ में, तो क्या होगा, आयरन किलेशन हो जाएगा और एब्जॉर्प्शन में प्रॉब्लम होगा. सो दीज थिंग्स किलेट्स द आयरन and decreases the absorption. Increase hepcidin expression, especially in cases of inflammation. Chronic inflammation is there, then hepcidin will increase. There will be increased store of iron, but it won't be absorbed, it won't be utilized. So these transferrin functions are increased in iron deficiency, and 33% binds to iron. So total iron binding capacity is 33%, because 33% of the transferrin will bind to iron. And transferrin saturation, this is important, this formula, because this is used clinically. Transferrin saturation percentage is equal to iron into 100 divided by TIBC. So what lab gives you is iron and TIBC. Okay. So transferrin saturation you have to calculate based on this formula, iron divided by TIBC and into 100. So this is transferrin saturation. If it is less than 10%, it means iron deficiency is there. Intracellular iron transport, so mainly whenever cell the transfer of iron need to be done through the membranes, it will be converted into ferrous form. It goes to my endocytos, then goes to mitochondria, and then to and some part of iron will go to ferritin and make the hemosiderin. So this is storage part. In mitochondria it will be utilized. So ferritin is storage form of iron. Normal value is about 12 to 200 approximately, exact I don't remember right now, but less than 12 microgram per liter ferritin if it is there, then it is suggestive of iron deficiency anemia, and this is the most sensitive indicator of iron deficiency. Extreme ferritin values should be interpreted with caution. False rise in inflammation, autoimmunity, connective tissue disorders, liver disease and malignancy because of acute phase reactant. And mechanism of rise of ferritin in as a acute phase reactant is during inflammation, IL-1 beta, TNF and interleukin 6, these will release, and these will increase the expression of hepcidin, which will lead to increased storage and decreased utilization of iron. So that's why ferritin will increase. So ferritin value, higher value should be interpreted with caution. Clinically we have to see the patient and find out whether any inflammation is there anywhere in the body. If chronic disease is there or inflammatory disease is there, then soluble transferrin receptor may be a good indicator of iron deficiency. This soluble transferrin receptor will be decreased in aplastic and iron overload, increase in ineffective erythropoiesis and iron deficiency anemia. So it is increased in iron deficiency anemia and not affected by inflammations. That is the advantage, but it is not available in India, at least. Only research based it can be done. So iron deficiency, there are phases: pre-latent phase, latent phase and anemic phase. Pre-latent phase, only tissue stores are depleted, so ferritin is low, okay. And latent phase, reticuloendothelial macrophage iron store depleted, so iron, TIBC, transferrin saturation, soluble transferrin receptor or reticulocyte content of hemoglobin CHR. So, all these will be decreased in latent phase, but there is no frank anemia. So, when frank iron deficiency anemia is there, then prolonged iron deficiency, bulk of RBC with low hemoglobin, hypochromic microcytic anemia will be there in last phase. The causes may be decreased absorption, poor bioavailability, एंटासिड थेरेपी, हाई गैस्ट्रिक पीएच, मतलब हम पेंटोप्राजोल भी ले रहे हैं और आयरन भी ले रहे हैं तो वो थोड़ा एब्जॉर्प्शन कम करेगा. ब्रान, टेनिन, फाइटेट, स्टार्च, अदर मेटल्स लाइक कोबाल्ट, लेड, लॉस